I do see a lot of blame that still occurs in our in all of our kind of treatment environments. And most of that blame occurs when the provider or the person or the professional, the nurse or, the related specialist is not as familiar with autism, or does not just doesn't know what to do and is frustrated by like how to figure it out. And so deflecting the blame is really a coping strategy that they employ, not to harm the person, but to kind of relieve themselves of the stress of I don't know what to do. So it's a really complex situation. When we look at the history of understanding behavior, Brian Iwata was key in this, and it is behavior analysis. And I know there's a broad base of feelings about ABA, and that I am broadly trained as a psychologist, but also specifically trained in behavior analysis. And so when he developed what we call the functional assessment, and it was an analog functional analysis, he was able to actually identify really specific conditions where self-injurious behavior was really communication for very specific things going on in the environment. So he developed what he called these primary functions. And there's been a lot of research on since those preliminary articles were published in that work. But it still lays this really good foundation that is still super helpful when we're treating challenging behavior, especially severe challenging behavior. So those 4 functional behaviors are actually universal. They're not specific to autism. He did most of his work in developmental disability, so it wasn't just autistic folks. And so, and this, you can apply this to your children at home, your husband, your wife, your significant other, whoever is in your family. We can look at behaviors and kind of lump them into these categories. So escape is just, procrastination, trying to get out of things we don't like, avoiding it. We can do these in really appropriate ways and very inappropriate ways. So our goal is to teach people to do these, to get this need met in an appropriate way versus using severe challenging behavior to get out of those things. Same thing for attention or relationship seeking. We might have a child at home, neurotypical, who is a class clown and loves to get attention and might even get a little bit of trouble doing that. But we can also have individuals who don't know how to get attention other than to use really severe situations. I have a young man yesterday I was just working with, and he is autistic and he has a trach. And when he loves being in the hospital. He is an adult now, and he cannot find a day program that will support him because of his medical needs. And so it's been a real challenge. His mom is lovely and she supports him, and he has staff, but he doesn't have a day program, and he really misses all those people. So when he comes in for his medical care, he hates to leave because we all love him and he gets lots of good positive attention. And so leaving is a challenge for him, and it makes me sad, but he will actually pull that trach out, pull his G-tube out, and do all sorts of things to try to prevent himself from going home. And those are kind of attention seeking behaviors, and also just I want to stay kind of a thing. I want to avoid leaving. It's a kind of multifunctional. But if we understand the distress he feels, where I don't want to be home, I'm stuck there a lot, I don't get out as much. It's really heartfelt in terms of what he's going through, and how do we help him get a better, robust set of circumstances to help him have a good quality of life, so that the hospital isn't where he seeks his quality. Anyway, each of these individual things can be broken down, and it makes it really simple and simplistic. But I don't want to say that that's the end all be all, but it does provide us this really good foundation for situations where I can look for what's a pattern of a child. So give another quick example. I had a adolescent that I worked with who came in with his self-injury was so severe he'd almost lost all the skin on his face. He was completely raw, and he did end up developing cataracts and later a detached retina, even with good quality treatment. And we did find out he had some other comorbid things going on over time. But anyway, when he first came to me, he was not able to even go in the classroom. He couldn't get in anymore. So it started with, he'd go to class, he'd have demands placed, he would have a big outburst, they would take him for a walk, he would calm down, they would go back, they'd do the same repeat. So every time he had an outburst, they took him for a walk. And so you can see how this would quickly develop of pretty soon. He's learned pretty quickly, if I have an outburst, I get to go walking. So then pretty soon he started having behavior before he even entered the door to the classroom. And later they weren't even able to go down the hallway that had the door to the classroom. And he had just kind of shaped up the staff to basically say, I can go to school and walk all day and that's all I'm going to do. And then I'll go eat and then I'll walk some more. And so they couldn't get him in any functional way in the school. And so he needed treatment to help him get over that. So we worked on that. And his primary function then was escape. He had all sorts of things going on, but that was the primary thing he came in for. So we use this mechanism to help drive kind of what we have to do. And we had to teach him that actually doing work isn't a hard thing and learning is a really good thing. And we had to kind of undo that heavy desire to avoid any learning environment.